Welcome to Friendly Pharmacy 5. Today we will be speaking with epidemiologist Dr. Raywat Deonandan. Dr. Raywat Deonandan is an associate professor at the University of Ottawa. He has a PhD in epidemiology and biostatistics, a Master's of Science in Physiology from the University of Toronto, and a Bachelor's of Education in Math and Sciences from the University of Toronto as well. He completed his Bachelor of Science in Physics, Physiology, and Anthropology at the University of Toronto. Here I am with Dr. Raywat Deonandan. He is an epidemiologist from the University of Ottawa. Dr. Deonandan, this is the second time you've come onto the Friendly Pharmacy 5 channel. Thank you so much. It was almost exactly 1 year ago, almost to the date that you were here last time.
Wow.
Mm-hmm.
And since then, I've lost a lot of hair.
You look a bit different. A lot has happened.
A lot has happened.
You have been in the media. I mean, you continue to be in the media, on TV, articles. You've been solicited for a lot of your advice over the past 18 months. Are you still keeping a tally of how many media interviews you've done?
Yeah, I have records of about 2,000, but I know about 3,000 have been done. So yeah, it's a lot. Yeah. I count this as well. So this is one of the 3,000.
Yeah, of course. That's a lot. And it's important that people know you don't get paid for this.
That is correct. It's important that professionals give to the community. We take a fair amount through the course of our careers, and this is our opportunity to, for the taxpayers to get something back.
Yeah. Well, it's been really neat to watch you and to listen to you and learn from you all about science communication. And yeah, that's been really, for me, that's been really great. So I was thinking about our interview today, and I thought, here we are again, heading back to school, kind of in a similar place as, chronologically as we were last year, but also very, very different. I'm from British Columbia on the west coast of Canada. We often have there'll be an earthquake one night and we'll get a tsunami alert. And then, the next morning we'll wonder, is there going to be a tsunami warning? And I think there's a little bit of anxiety as we approach the school year and the fall, as we see Canada now in its fourth wave. It almost feels like there's this impending doom, like, is the tsunami coming? Is it already here? And so I'm wondering from, your eyes, from your lens as an epidemiologist who understands the numbers and you understand exponential growth and you understand Delta and these variants, as well as the vaccines, how do you see this maybe in Canada, but also globally? Well, how does this look to you?
First, I put my glasses on because it's really bright where I am.
Yes,
I don't mean to be rude.
No problem.
It's an interesting question because the situation locally is I think quite different from the way it is globally. Globally, the pandemic is going to rage on for some time. Locally, we got a chance at controlling it relatively quickly if we do certain things appropriately. As all the experts have been saying, this is right now locally a pandemic of the unvaccinated. So what's different now from last year at this time was two things. One is Delta is here, which is a whole new beast. We can talk about Delta. And the second thing is we have this amazing effective tool called vaccination, which is not our silver bullet, but our effective tool for really getting society back on track quickly. So where are we in the pandemic? It's a good question. I think globally we're closer to the beginning than the end, unfortunately. But locally, I think we're nearer to the end in the sense that we are near the end of the waves, and we may be entering the endemic phase in a few months, depending on what we do next. And the endemic phase is no picnic, but it's tolerable, and it's kind of inevitable in some ways. So I think we're going to get our lives back in a large sense in a few months, but 2019 normal may not come back for some time. So that's the bad news. The good news, though, is that businesses probably will not be shut anymore. Schools will probably be open. Our livelihoods will not be threatened to any large extent once this wave is tackled. I hope.
Yeah, I know it's really hard to make predictions. I don't like to put anyone in that kind of situation. I've been put in that situation myself, and it's a dangerous place to be.
Predictions are difficult to make, especially about the future.
Yes. I agree. That's excellent. So you mentioned Delta there. How has Delta changed this game for us?
Right. So A year ago, when we were talking about the prospects for herd immunity and vaccination, some quick back of the envelope calculations suggested that you needed about 70% of the population to be immunized before herd immunity kicked in. And immunization is via vaccination or via recovery from infection. And that's based on the contagiousness of the virus. So the herd immunity threshold formula essentially has one component, that is the reproduction number, the number of new people that an existing infection can infect. And COVID classic, as I called it, maybe that number was 2 or 3. So over the course of infection, a COVID infected individuals can be expected to infect 2 or 3 additional people. Delta, that's maybe 5 or higher. It's really, really contagious, maybe as contagious as chickenpox, some people are saying. And if you don't know, chickenpox is an extraordinarily contagious disease. So the contagiousness ratchets up the expectation for the herd immunity threshold, but also Delta challenges the vaccine efficacy a little bit, brings it down from about 95% to maybe 88%, depending upon which data you look at. And that also ratchets up the herd immunity threshold. So that takes us probably above 90%, maybe out of reach entirely, maybe. We'll see. We never really know until we're there whether we've reached herd immunity. And herd immunity isn't some magical thing that you cross and everything's done. Because immunity isn't spread across the population homogeneously, it happens in clusters. Populations are going to dip in and out of herd immunity. So regardless of what happens, we're going to see clusters of infection popping up here and there for the next few years. But with sufficient vaccination, this shouldn't be a threat to A, our healthcare system, B, our society, or C, even our health, if we're mostly vaccinated. So that's how Delta has changed the game. It's really prolonged the misery because frankly, 4 months ago, I was predicting we'd be done by this by now. I thought we'd have sufficient vaccination, that the Alpha variant, which is dominant, would be completely beaten and would be on the path towards complete normal. But Delta has really thrown a wrench into that plan. I feel really stupid for making that prediction a few months ago. But yeah, that's what's happened. And the other bad news is that so long as this disease is boiling over in other parts of the world, especially low-income countries, the prospect of new variants emerging that are worse than Delta remains real. Maybe not likely, but certainly possible. So that's why my current rallying cry is, let's vaccinate the world as quickly as we can to stop this suffering and just to take me off of TV. So you never have to see my face ever again. Vaccinate the world and make me go away. So that's what we need to do.
Well, and you mentioned there the vaccine efficacy, and I just wanted to clarify for people, we get very fixated on these efficacy rates, and this is symptomatic, right? So I think you said that
yes,
this puts the vaccines at about 88%. Is that what you said against Delta?
Yeah,
and
again, depending upon which data you look at, the computing vaccine efficacy is not clean.
Right.
It's not a one and done. Depends on when the calculation is done, which population it's against, which outcome measurement you're looking at, and so forth. But yeah, in general, the vaccines are doing really well at preventing symptomatic infection, not as well as preventing asymptomatic infection, pretty well at preventing serious disease, extraordinarily well at preventing hospitalization, and almost perfect at preventing death. So vaccines in general don't do well at preventing infection entirely. That's called sterilizing immunity, and very few vaccines manage that, frankly. I struggle right now to think of one that does. Mind you, the Moderna vaccine, during its animal trials, showed signs of sterilizing immunity, which is why I was so bullish on that vaccine. But even without sterilizing immunity, vaccines do a tremendous job. I always bring up the example of rotavirus. Rotavirus absolutely does not prevent asymptomatic infection. But because so many kids have the rotavirus vaccine, it's rare to see cases of rotavirus now. So it is possible with a vaccine that does not provide sterilized immunity to nevertheless make the disease effectively go away.
Very, very interesting. There's so many questions that I'd love to ask you. I'm trying to pick here. We're talking about these vaccines, and we are seeing breakthrough infections. So the vaccines, they were never 100% effective. We knew that.
Yeah.
And we are seeing breakthrough infections. Now, we are also seeing that with Delta, people can carry they do carry higher viral loads. And we are seeing that people who are vaccinated can transmit. And some people have said, well, what is the point then in being vaccinated?
Right. So the point, first of all, is being vaccinated prevents you from having serious disease, keeps you out of the hospital, and keeps you out of the morgue for the most part. There are going to be some cases where it doesn't, but
Sure.
overwhelmingly it does. Some people suggest that we should stop calling these breakthrough infections and call them spillover infections instead, because a breakthrough infection implies that there's a wall of immunity and the viruses somehow find a way to penetrate that wall and the wall has come crumbling down. But the wall's still standing. What's actually happening is that there's sufficient virus circulating that it spills over and infects people on the other side of that wall. And who is getting infected? Well, it's probable or possible or probable, I don't know, that the vaccinated people who are getting infected are those who did not mount a sufficient immune response. So maybe you mounted a minimal immune response and you're getting a little bit sick. Maybe you mounted no immune response and you're resembling an unvaccinated person. That's going to be a small number of people. We don't know who those people are. Might be you and me. We never know. So that's why it's important to minimize the probability of exposure by using masks and other tools to keep the level of virus circulating low until everybody is vaccinated. And so the level of virus circulating is so low that it becomes unlikely that you and I will be exposed. So it is possible for a vaccinated person to become infected. That should not be a reason not to be vaccinated, because as I mentioned, number one, it prevents you from getting seriously sick. Number two, even though you've been vaccinated, some data is suggesting that a vaccinated person carries the same viral load as an unvaccinated person once infected. What does that mean? It means the amount of virus measured in their nasal passage is similar. And that suggests that then if I'm vaccinated and infected, I can pass it on to someone else just as easily through breathing on them as an unvaccinated person would be. However, two important caveats. One is I am much less likely to be infected because of my vaccination. And two, some data out of Singapore and some other places now confirming it, that a vaccinated person carries that viral load for a much shorter period of time. Also, that viral load tends not to descend into our lungs, so we're less likely to cough it out. Right? As a result, a vaccinated person profoundly less likely to pass on disease. As a result, vaccination remains an extraordinarily good tool to reduce population transmission. And all the data is bearing this out. A lot of stuff there.
You mentioned Singapore. I saw in one of your posts recently that you kind of thought their approach was maybe the way to go. Can you tell us a little bit about that?
Yeah, it's going to be probably the future that we embrace. So Singapore was going for COVID zero. COVID zero is when you eliminate all the virus in your country. And I was a big proponent of COVID zero. New Zealand did it well. But Delta might be so insidious that it makes COVID zero nearly impossible. And Singapore is abandoning COVID zero, and instead they are embracing the idea of managing an endemic disease, which is not ideal, but it's possible once you've got a really high vaccine uptake. Okay, so this is different from what people were saying a year ago, like live with the disease, tolerate the infection. No, you should not tolerate the infection if you have a tool to avoid infection. So we have that tool, that's vaccination. So Singapore has an extraordinarily high vaccination rate. And so they anticipate that those infections that do occur will be manageable. And that's kind of what endemicity means. It means that we won't see waves anymore. And we can talk about why waves happen, but we'll see a constant low level of infection that percolates, but is not life-threatening to most people, because vaccination and immunity is so common. And as a result, the healthcare system is not likely to be challenged. And so they can open things up, they can have their travel and trade and all that stuff. But people are aware there is a virus circulating. That's like a really bad flu now. Kind of what people were saying, the wrong people were saying this a year ago. Now it's kind of true in an environment with extraordinary vaccination. So some experts are suggesting that that might be the future for us, is accept endemic disease once we get a really high level of vaccination. And maybe we'll get such a high level of vaccination that the endemic level will be so low, it's not even noticeable. It's not even noticeable. Like what's been eliminated, polio has been eliminated from Canada, right? We managed to vaccinate sufficient people to drive it out of our borders. It's not eradicated though. Chickenpox, do we have herd immunity for chickenpox? Maybe, maybe not. People are unclear about this. You know, it still exists, it still percolates. So that's kind of an endemic disease. It's always around, but it's such low levels, we don't really think about it. You know, so we have precedent for this. It's just that right now, COVID is a novel disease. So we've never seen it before. So it's threatening to our physiologies. In a year or two, it won't be novel anymore. Sufficient people will have some kind of immunity that it will not be a challenge to our physiologies. That's the theory. And it seems to me that increasingly it is likely that we will take the Singaporean path, as we do not have the stomach for COVID zero, and COVID zero might not be possible. But who knows?
Yeah, I was really hopeful about COVID zero as well. I thought that that was a fantastic idea if we could have gotten all of our ducks in a row and done it. I mean, we are seeing now that there's hesitancy in these countries that have not really seen the serious disease. And I mean, there's a lot of different factors for that. But when you talk about Singapore having a very high level of vaccination, how high are we talking?
I don't remember. I think it's like 80%, I think.
80?
Yeah.
Okay.
Which is not nearing the herd immunity threshold that we think is needed, like 90%.
Yeah.
But if I remember correctly, it's 80%.
Okay. Okay. And then
I'm not sure which vaccine they're using, by the way. That matters. So
yes.
we want the highest efficacious vaccine possible.
Yeah. Yeah. And then, you know, Israel, right out of the gate, was just incredible to watch their vaccination program, and it was like world class. Everyone was watching them, and then they just seemed to kind of, I don't know if they lost their way. What did you see? Did they open up too soon?
Yes. So they had all the right tools, and they opened up too soon, first of all. Second of all, they've always had a disadvantage. They have a lot of young people, more than we do. So they have a lot of people that are ineligible for vaccination. So their ceiling for the proportion of people able to be vaccinated was always low. As a result, the number of susceptible people in the population was always going to be untenable. The disease would always find a foothold there. They never closed schools. They maintained this corpuscular system. I forgot what they call it, the cellular system, I think they called it. But they suffered through a lot of school outbreaks as a result. So until we can vaccinate children, that's always going to be a challenge, because epidemics are about susceptible populations. Who's susceptible? Anyone who's not vaccinated. And if susceptibility comes in clusters, especially geographical clusters like schools, then that's a hotbed for potential infection. So that's the challenge here. And Israel too, because they started early, they may be the first to experience waning immunity from vaccination, and they stuck to the original 3-week interdose interval, which was what the clinical trials recommended. However, we know now that the wider interval offers more durable, robust immunity. And luckily, Canada, we have a very wide interval indeed. So we might be better placed than Israel to withstand longer assaults against the population.
You mentioned schools there as well. And so we know that, in Canada and I guess worldwide right now, children are not vaccinated. And we have Delta here. And some people have said that Delta, you will be vaccinated and Delta will find you, or you will be unvaccinated and Delta will find you. So what do you agree with that? And
yeah,
what
I do.
Yeah.
It comes down to the crazy contagiousness of the disease again. And if the society is going to be open, then it stands to reason that everyone is going to be exposed at some point. May not be now, may not be 6 months from now, it may be 5 years from now. But eventually we're going to be exposed. So when the exposure comes, do you want to be protected or not? That's the question here. And people have been conflating exposure and infection. That rubs me the wrong way. I've seen some YouTube commentators they're quite intelligent people, just using those words interchangeably, saying like, we're all going to be infected at some point, so get vaccinated. No, we're not all going to get infected. We're all going to get exposed. And a proportion of that will become infected, and a proportion of those infected people will do poorly. But your probability of that happening diminishes along that scale with good vaccination.
It was looking like maybe even just a few months ago, things changed so quickly. It was looking like this to me. Maybe it wasn't to you. Maybe we wouldn't need to vaccinate children. There was the discussion around children, generally, they don't really get severe disease. There was a lot of hesitancy. Do we really need to vaccinate the kids? Now we're seeing serious cases in the US with Delta. What is your stance on how we should approach vaccination in children? I mean, from what I've seen, it sounds like we won't achieve herd immunity without it now.
So the pushback would be, if we can't get herd immunity, then why should we push it on children? What's the rationale? And I get that. So I'm sympathetic to parents who are hesitant to vaccinate their kids. I have an old child too, and the thought of sticking anything in him just fills me with dread, especially a relatively new drug. It comes down to the risk versus reward. So the risk of getting COVID was small for children a couple of months ago when we thought the end of the third wave might be the end of the local pandemic. But the risk of being exposed and getting COVID has now been ratcheting up significantly. So with increased risk of getting the disease comes increased risk of hospitalization, long-term disability, and death. Still low. So in the USA, there's a risk if you're a child who gets infected, you have a 1% chance, 1 to 2% chance of being hospitalized, and a 0.01% chance of dying, which is a very, very small number. But the law of large numbers says that a small proportion multiplied by a large number of people means someone's going to die. And when that someone's a child, that's not a good thing. And if it's your child, it's particularly not a good thing. So my feeling is I would vaccinate my child against COVID-19, even given the presumably low risk immediately, because at some point, as we've established, he's going to get exposed. And when that happens, I want him to have a fighting chance against hospitalization.
And I know you're not a medical doctor, so I don't want to, ask you necessarily a medical question that you're not comfortable with, but from what you've seen and what you've read, do you think that this will be a disease that we will eventually pass on some kind of immunity to children, or will children always need to be vaccinated for this?
Well, there will be, my understanding is it's not possible to genetically pass on immunity.
Okay, yeah.
So if you think about the Spanish flu, what happened to the Spanish flu? It raged along for 2-3 years until so many people in the world got it that there was sufficient immunity built into the population that the disease could not find a sufficient foothold later on. It came back a couple times later in different forms and caused some trouble, but did not stop the world again. And the Spanish flu still pops up now and again. Its descendants pop up in various versions of the flu today, and usually cause small amounts of we call them pandemic influenza. It's not nearly the same globe-stopping endeavor as we have here, but it fails to again have a foothold because sufficient people have biological memory of what happened over the course of the first few decades of the 20th century. Now it's possible that when those people die off entirely, there won't be any immunity left over. So with COVID, it won't be novel anymore after a few years. And so we will have some kind of lingering immunity. With the Spanish flu, again, why did it kill off so many young people early on and not the older people? Because there's a theory that some version of it was probably around in the late 1900s. And those young people who got it then were the old people in the early 1900s who saw the Spanish flu and had some immunity built in. So yeah, our children won't have immunity from us, but they will be exposed to it in small amounts over the course of the next few years that maybe there'll be sufficient immunity. I mean, there's something called variolation, where you get tiny exposures that may be triggering some immune response that is sufficient to keep the disease out of your body. I don't know if that's going to happen here. It's theoretically possible, I guess.
It's amazing that there's still so many unknowns. It feels like we've been in this forever, but it's less than 2 years, right?
Look, man, it's literally less than 2 years, and the amount of stuff we know is extraordinary, given the full court press we've had. Any other disease, it would take us decades to get to this level of knowledge, and we still know very little.
It has been phenomenal. It's been hard to keep up with.
I gotta give a shout out to the journalists because they're up on this much better than many scientists are, and I rely on them to keep me aware of new studies. They've been a really important part of this entire response.
Definitely, and this is not their area of expertise, so they've had a real learning curve there for sure. Yeah. So just to wrap up kind of the conversation on children, since that's kind of what we were discussing, moving into the school year, we've got a lot of anxious parents. We were anxious last year, anxious this year. What are your concerns, and what can we do as parents to protect our kids? What mitigation measures do you think that are the most important?
Oh yeah. Well, obviously, we got to make sure that anyone they come into contact with have been vaccinated. Why? Because as we've established, vaccinated people are less likely to have infection. And once they are infected, less likely to be infectious for a longer period of time. Therefore, at the population average, your child is less likely to be exposed to the virus if they're surrounded by vaccinated people.
Yeah,
it's a nuanced way of thinking, but that's the population dynamic way of thinking. So Maybe vaccine mandates for schools. Definitely everybody in your house who can get vaccinated should be vaccinated. Maybe don't let your kid associate with other kids with unvaccinated adults in their life. That's a hard thing to do, but that would be ideal. The best way to keep COVID out of the school is to keep it out of the community. So everyone in the community has a role to play. Get vaccinated. Don't go to raves. Don't do stupid things that increase your risk, because your risk eventually becomes a school risk. Number one. Number two is, I think masking is important still. The data is pretty clear on this. I don't get how the anti-maskers still cling to this narrative that it doesn't work. Masking reduces the attack rate by up to 40%. There's data out of Bangladesh I just saw that regular masking of low quality homemade cloth masks reduces the incidence by 9 to 20% in the village environment, which is not an ideal environment. So masking absolutely works. The ecological analyses looking at populations that mask versus that don't mask tend to show that the masked populations have lower incidence rates, lower hospitalization, death rates, et cetera, et cetera, et cetera. Masking works. So COVID is airborne. I'm on that team, and that team is right. And as a result, good quality masks are important, I feel. So an N95 is better than a non-N95. However, a non-N95 does offer some limited protection against aerosolized particles. I forgot the exact numbers I was reading last night, but the N95 masks, which are fitted to your face, offer the best protection against. You know what aerosols are? Cigarette smoke is an aerosol. So imagine someone is smoking and exhaling clouds of COVID around you. They linger that long, and you walk through that cloud and suddenly you're exposed and possibly infected. So masking. Number three is symptom checks. Why is that important? If you are symptomatic and you have COVID, like you've got coughing and sneezing, you're more likely to produce aerosol particles. You're more likely to have a high viral load, more likely to be infectious, such that people around you will be infected. So taking symptomatic people out of the equation vastly reduces the probability that the environment will be an infectious environment. Won't be perfect, but it vastly reduces the probability. We know that asymptomatic infection and spread is a thing, but it's less likely. Are we up to four? Number four is ventilation control. And this is the controversial one, because as I said, COVID is aerosolized. Investing in HEPA filters and air purifiers is the right thing to do. It's expensive and time consuming. So the way that filtration systems work, there's something called the MERV rating.
Yes.
Most buildings have a MERV up to 14 or so, and but HEPA is above MERV 16, and HEPA filters out, I think, more than 99% of particles 0.3 microns in width. So that's what you want. You want a filter that takes out the smallest possible particles. So a HEPA filter is ideal. If you haven't got a HEPA filter, then I guess a MERV 14 to 16 plus really good masking and other qualities. I'm not an engineer, talk to them, but high quality filtration is important. If you haven't got filtration, keep the windows open. That's hard in winter. So ventilation is important. Administrative things you can do in addition to symptom checks, in addition to keeping only vaccinated people around, is to make sure your school has a lower class size if possible. And this is controversial too. And the reason for this is twofold. One, the fewer number of people in that class, the less likely one of them is going to be infected, and therefore the less likely that everyone in that room becomes infected. And the second reason is that if that entire class has to be sent home for a week, the entire school is not disrupted, just that smaller cohort. So that's what I recommend. I don't think schools should be closing this time around. I think we have the tools to manage it, and if schools are closing, it means we have failed. And by the way, if everybody else gets vaccinated, that means public health can move all of their assets to focus on schools. So it's selfish in my mind for an adult to choose not to get vaccinated without a very good reason, because you are saying, I'm going to withhold these resources in case I need them, when in fact the children need them in the schools. So it's a zero-sum game. The resources aren't infinite.
It has been something that's been interesting, is our difficulty to think about the other or our neighbor or our community, or to take action that doesn't necessarily.
This has been the fundamental issue throughout the entire pandemic response, is understanding individual risk versus population risk, individual responsibilities and rights versus responsibilities of the population. I'll give you the obvious example is people keep crowing at me. Why should I be afraid of a disease that's 99% survivable?
Yeah.
Maybe you shouldn't, but would you accept a surgical procedure with a 1% chance of death? Think about it really. That would fill you with terror, frankly, right? They do exist, these surgical procedures, and people who are offered them are just stultified for weeks before deciding. And imagine if you're driving to work on the freeway. How many cars around you do you see? 1,000, 10,000, 100,000, a million? If 1% of those die, that's a lot of deaths, right? So 1% of a large number is an exceedingly high number. And yet we keep focusing on, well, my chances of living are 99%. Yeah, that particular moment in the day. But multiply that every moment throughout the day, every day throughout the year. Suddenly your chance of something bad happening increase dramatically. So there's built-in innumeracy as well as some philosophical problems here with our inability to understand population risk.
It continues to be astounding what people come up with. I don't know how else to say that.
I'm sympathetic. I mean, so people, I understand this is in many ways a conceptual pandemic. We're not looking through the window and seeing bodies strewn across the ground as we would have during the Black Plague of the Middle Ages. When we think of pandemic, we think about wheelbarrows full of bodies. People aren't seeing that, so they don't get the seriousness. The seriousness is our healthcare system might crumble. And if that happens and you suddenly are in a car crash, guess what? You're not going to survive. Or suddenly you need an appendix taken out. Guess what? There is no bed for you. So everything else downstream crumbles. And that, again, is a systems way of thinking that we have not empowered the population to really grasp yet.
So just thinking of globally here, how should we be approaching this from a global perspective? Do you think that I know we already talked a bit about vaccinations. The United States, like you said, they did that 3-week dosing interval, and they're seeing some waning immunity. They're rolling out booster doses. I think initially it was an immunocompromised, but I think that they're going to roll it out more generally soon. Do you agree with that approach?
I don't agree with it. I understand it. It's their vaccines. They paid for it. They make it. Do well with it, I guess. It's short-sighted. So long as the pandemic boils around somewhere, we are all constantly at risk. You want to stop having this conversation? You want to have you and I talk about something else at some point soon?
Yes.
We need to solve this problem in Bangladesh, in Mexico, in Nepal, right? In Chad, in Mali, Sub-Saharan Africa, right? The poorest countries in the world need vaccines, and they need therapeutics, and they need hospital support. They need mitigation tools. They need masks. They need all these things that we have. Frankly, it should be a Manhattan Project level effort by the world. We have the resources. We don't need to invent anything new at this point. We just need to produce more of them and ship them to the right places. And in a matter of months, we can have this fixed. When instead we're focused on making sure that we have perfect immunity so that we can go to the restaurant or something, it's short-sighted. We have an intermingled global economy. And if Chad and Mali fall and suddenly we have infection floating from Africa into Europe and elsewhere, and economies are falling, etc., we're all going to suffer. It's a problem. It's a problem. There should be accommodation for those who didn't mount an immune response, the elderly, the immunocompromised, absolutely. But for most people, we have other tools like masks, and distancing to help us wait while we have more immunity around the world. When you look at the statistics of people who are infected, there are a large number of vaccinated people in that number. And that doesn't mean anything. In fact, as time goes on, that number will increase, that proportion will increase. That's a good thing. That's a confusing people to understand. So we call that the base rate fallacy. Israel, they released some data earlier in the year showing that 50% of their infections were among the vaccinated. And that was terrifying to people. Oh my God, vaccines are failing. No, they're not. It's just that so many people are vaccinated that among those who get infected, of course, the vaccinated are going to be represented, and the more vaccinated people there are, the more number of them there will be amongst the infected. So the example I give is seatbelts. So now that we have pretty much 100% of the population wearing seatbelts, car crashes leading to fatalities are much fewer, but they still happen because seatbelts aren't perfect. However, 100% of car crashes leading to fatalities were among seatbelt wearers. Doesn't mean seatbelts don't work. That means that everyone's got seatbelts, and therefore that's who you see. So when 100% of people are vaccinated, you're still going to see some COVID cases, and 100% of those will be amongst the vaccinated. Doesn't mean vaccines don't work. It just means a lot of people are vaccinated.
Mm-hmm.
So that's, again, a little bit of a fallacious way of viewing the data that people need to be aware of. It's called the base rate fallacy, and anti-vaxxers weaponize that message to great extent. And some of this also drives the narrative that immunity is waning. It's not waning that much. So I think there's a lot of panic in the media around that, and it's totally unwarranted.
And I know, there's talk about how these vaccines, there's this uncoupling, right, of cases and hospitalizations, and we're already seeing that in the data. So when we're seeing these cases rising, of course, we should be concerned. We have people who are in our community who still aren't vaccinated. We do want our community transmission to be reduced, but we're not seeing the hospitalizations follow like we were. Is that accurate?
That is accurate, yes. That's why it's important now to track the cases amongst the unvaccinated, because the proportion that end up hospitalized there will remain steady. And places like Germany have already decided to stop mass testing because they've accepted that with all the vaccination, it's not a meaningful statistic anymore. I'm not sure I entirely agree that we're there yet. I think I still want to see those numbers, and people still need the comfort of knowing they can get tested when they want to. But there will come a time when testing is irrelevant from a data perspective for the most part. What we care about then is, again, the hospitalizations and as you mentioned, the deaths. We're getting there, and so don't be surprised when the testing numbers aren't reported anymore.
And that'll be a good sign.
It will be. And what we need really is rapid tests. We haven't talked enough about rapid tests. And they're so confusing for people because it's unclear how to use them. The thing about the rapid test, the rapid antigen test, is that they detect the antigens, the protein on the surface of the virus, whereas the PCR test detects, the RNA, the genetic material in the virus. And the PCR tests are really, really sensitive. They find even the tiniest hint of genetic material, leading to some people suggesting it has a high false positive rate. It doesn't. It just has a tendency to detect cases that aren't infectious yet, or cases that were previously infected, but they're still cases. The rapid tests, if you test positive, you take that to the bank. You are definitely positive, and you're really positive that moment. You're infectious that moment. If you test negative, you don't take that to the bank because you might still be infected. You're just not really infectious at that moment. But as a result, it's a powerful tool. I can test myself on a daily or many times per week basis to know whether or not I should take myself out of society. So as we download the responsibility for self-management to the people by giving them rapid tests, then public health is free to do other things. So imagine if I can tell, I've got COVID today, I should stay home. Suddenly, I'm not at risk of being a spreader. It requires some responsibility on people's part, but for the most part, people will do the right thing, I think. So I think the next step has to be to deploy subsidized rapid testing for the entire population for regular usage, and using that tool, we get back to normal. The rapid tests, though, are not a substitute for vaccination. They're being used as a bridge to vaccination for people who are hesitant. Instead of vaccination, I'll test myself regularly. It's not a substitute because of the high false negative rate, right? The only substitute for vaccination is vaccination. But it's, again, a bridge to get there.
And we still do have quite a ways to go as far as vaccination goes in Canada. I know that in our press conference for British Columbia yesterday, there's still over 100,000 people over the age of 60 that have not yet been vaccinated. I know you'll agree with me on this. There has been a pandemic of misinformation as well. And kind of breaking through that, I've seen some of the anti-vax, I don't know if you would call it content. I'm not sure what to call it. It's terrifying, and it's confusing for people. How do people decipher?
First, it's a kind of terrorism to my mind. And it makes me quite upset. People first have to understand science is at a disadvantage because science is slow and deliberate and careful. Science communicates via peer review. The average number of people who read a peer-reviewed paper, 2, not including the authors, right? The average number of people who see a YouTube clip talking about something more inciting, tens of thousands, maybe even millions. The old phrase, a lie goes around the world twice while the truth is still putting on its shoes. So science is at a strong disadvantage because the lie doesn't have to go through peer review or check its sources. So what people need to do is first ask themselves, is this message peer reviewed? Right? What they tend to ask themselves is the messenger authoritative, which is the wrong thing to ask. Because a lot of people have PhDs, a lot of people have MDs. Doesn't mean I know what I'm talking about. I've got a PhD in epidemiology, but don't ask me about kidney health or nutrition as people do.
Mhm.
That's not my expertise.
Mhm.
So people ask radiologists about epidemiology. Don't do that.
Mhm.
No. And even if your expertise is virology or epidemiology, you still might get things wrong. That's understandable. So beware of arguments based on authority, first of all.
Mhm.
Second of all, look at where it is being offered. Is it via a Facebook post, a tweet, a YouTube video? If that's the case, just throw it away. If
Mhm.
it's not part of a peer-reviewed journal, it's not science, frankly.
Mhm.
And the response is going to be, well, the journals won't publish the truth. Really? If that's the case, then you define the truth a little too strangely for me. And really, I don't know where the common ground is for this conversation is.
Mhm.
The other place to look is university websites are well curated for information. So if you see it on a university website, it's probably good. And you won't find misinformation there. Government websites are slower to be updated
Yeah.
and are often rife with some misinformation because of communication failures, strangely enough. The CDC has misstepped many times. WHO misstepped many times. Government of Canada has misstepped a few times.
Yeah.
So that's unfortunate. There's no obvious way around that except to keep track of the corrections they make later on. The politicized nature of government websites is problematic. But I always drive people to the university websites like Johns Hopkins,
Yeah.
excellent site for COVID stuff,
Mhm.
and peer-reviewed journals, peer-reviewed publications, not pre-review. So a lot of people keep pushing pre-peer-reviewed stuff on websites they call the public health. What's it called? These repositories that are awaiting peer review. Most papers aren't accepted.
Mhm.
Just
Yeah.
because they're being submitted doesn't mean they're good.
Mhm.
So that's what people need to understand. And if you're in doubt, contact an actual scientist, and
Mhm.
maybe they've got time. You know,
Mhm.
I get a lot of emails every day. I can't answer all of them, but you know, when I can, I can.
Yeah. No, you
Actually, I
do.
shouldn't say that. I get a lot more emails now, but I help when I
You,
can.
you do a great job of that, but I know you have been drowning in them as of recent. It's hard. I understand it's hard for people. I've had a few things sent to me, and the way that some people who do have an MD or a PhD can mix some truths with untruth. And if you don't know how to pull that out, I understand how people get led astray. It's sneaky sometimes, and if we don't know what resources to go to and how to filter that,
Yeah.
and these days anyone has a voice. I mean, I might not be a pharmacist, right? I could, I am,
That you
but
could be lying. Yeah, you could be lying. It's true.
I could be lying. I have a voice. Anyone can
Yeah.
start a channel. Anyone can say they have a PhD, and even people who are educated, have these degrees, they also can say things that are
Be
not
wrong.
true, you know?
That's right. And that's what we're allowed to be wrong. That's okay.
Yeah.
Have a different position. Just don't misrepresent things. Another thing to consider is the pyramid of evidence. So
Yes.
Ivermectin is big in the news.
Yes.
And I've been dancing around talking about ivermectin. I don't really want to talk about it, but instead I'll talk about how we can think about ivermectin. If you don't know, ivermectin is a livestock antiparasitic that some people think is a COVID prophylaxis. And there's a huge political movement to push it into the narrative. So one, beware political movements. That's not science. Two is ask yourself, what is the quality of the evidence? And most people aren't trained to assess this. Well, I'll tell you, one of the first things to look at is the kind of studies that are being purported. Is it a doctor saying, I gave ivermectin to my patient and he got better? We call that case report. That's the second lowest quality of evidence. The lowest quality of evidence, personal opinion, right? So my opinion right now, low quality evidence. Up beyond that, it's case report. A doctor saw this in the practice. Okay, it's interesting. It doesn't mean anything. It just mean that the patient's kind of interesting. Above that, we have observational studies, like, I saw some people take ivermectin and some people who didn't, and the ones who didn't end up getting COVID. That's interesting. It's compelling. It's not conclusive, though, because other factors could be in play. The highest quality of evidence is the randomized controlled trial. And beyond that, it's the meta-analyses of high-quality randomized controlled trials. So that's why for these therapeutics and preventatives like ivermectin, we wait for the extremely high-quality meta-analyses of randomized controlled trials to tell the story. And so far, they're showing no effect, right? So that's why that evidence is weighted higher than these doctors in Mexico and Brazil saying, but I gave it to my patients, they got better. This happens all the time. We see endless doctors writing about, I gave my patient, eye of newt and had them sunbathe for 3 hours. They didn't get COVID. Okay, fine. That doesn't mean anything. What matters is once we've removed all these extraneous factors, what's left over? Looks like nothing. Looks like nothing's left over. Yeah. So that's what people have to be aware of is just because a doctor says they saw something doesn't mean anything. That's a difficult pill to swallow, pun intended.
Yeah, it's difficult, and ivermectin is one that people have been asking me to talk about as well on the channel. And so if you're watching, I have not spoken about it because I am listening and I am looking and seeing what's coming out. I know that Oxford has a trial going on right now. I think it's called the Principal Trial. They're looking into ivermectin, and I look forward to seeing that. There's been a couple meta-analyses, and the key that you said there is if you take a group of high quality studies and do a meta-analysis, and I think what's happened with ivermectin from what I've seen is that there's a mixture and there's a lot of low quality studies.
A lot of crap studies.
And do a meta-analysis, and the meta-analyses are showing mild evidence or mild to moderate. I don't know. So people think I'm against ivermectin. I'm not against anything that helps to get rid of this disease.
If I make a prediction, I think it probably ends up having some small effect. Probably does. But I don't think it's going to be a game changer, certainly not better than vaccination. Yeah. I'd be overwhelmed and just overjoyed if it is a great preventative.
For sure.
Then we are done. Yay.
Yeah.
But the way I look at the data, that's not what I'm seeing.
I want to wrap up here. I do have a couple of viewer questions for you, but I have one question of my own. You talked about variants and how, the vaccination helps to reduce the chance of more variants. And there's a variant that caught my eye recently, and it's the C12 variant. And I think did that come from South Africa?
Yes.
Okay. Does that one concern you? What do you?
They all concern me, but I don't let it take up space in my mind until it's been elevated to a variant of concern by the powers that be. And by the way, there's variants of interest, variants of concern, and variants of high consequence. And they're ranked based upon the variants challenge to our therapeutics, our diagnostics, and our preventatives, so vaccines. And so far, it's not clear if it's where it falls along that path. We have no variants of high consequence yet, thank God.
Yeah.
It might just be a variant of interest right now, and so I don't really care about it yet. And it's possible that Delta being so prominent will just keep it out. It kind of does that. Is it scary? It's scary in the sense that it might evade some of the vaccine immunity, some of it. But again, it's unclear. And I refuse to be concerned or upset about a thing until it's clear that I need to be.
That's a good stance to take. There's always these different things popping up, and it's easy to become concerned. But also another reason that we should focus on globally vaccinating, right?
Yes, absolutely. Stop the variant farms.
Yeah. Let me get to a few viewer questions that I had for you here. I know we did touch maybe on a little bit of this, but I'll try to be succinct here. Will Delta become weaker and be over in the coming months?
Will it become weaker? What does that mean? Will the virus itself mutate a certain direction? Viruses tend to mutate. Will it mutate in a more virulent or a less virulent way? It's unclear. Over time, and by over time, I mean like generations, decades or centuries, I suspect evolutionary pressures will drive a thing towards less lethality because it prefers to have hosts. But in the short term, anything could happen. So the second half of that question was,
will Delta become weaker and be over in the coming
over? Will it be over? It's not going to be over. It may be driven out by something worse.
Yeah.
But or sufficient vaccination will push it to the margins, so we deal with it like chickenpox.
We would love it to be over, but yes. We can't determine that. Is Delta causing more severe disease in children?
Right. That's unclear. I hate to be wishy-washy on this, but what we know is it increases a larger proportion of people can be hospitalized for it That doesn't mean it's necessarily more serious. See, that's the tricky part here. Because it's so contagious, it's affecting a lot more people. And so the hospitals are filling up faster. And because children are the single largest block of unvaccinated people, that's who you see. That doesn't mean it's targeting children, and it doesn't mean it's more effective against children. See, that's a tricky part of statistics. Mm-hmm. So the bottom line is we don't know. Now, there is some data out of Scotland and Singapore that suggests that it may be slightly more serious for adults. And that suggests maybe it is more serious for children as well.
The fact that we haven't been able to vaccinate children, I mean, in an ideal world, would we have just vaccinated all demographics at the same time? Yes. So no one was left out?
In an ideal world, if we had all the vaccines and we had complete safety data that was compelling, and we had the infrastructure and political will to do so, just get a jab and everyone simultaneously, and we are done.
Yes. Yes. What are the chances the virus will evolve to be more pathogenic?
The way evolution works is mutation is random, and so the environment selects for a mutation that is more amenable to the reproduction and survival of the virus. So that might mean more virulent, might be more pathogenic. It might mean less likely to kill because the virus survives longer that way. Right? So a number of things can happen, and it's impossible to tell which it will be.
You talked a little bit about rapid testing. Should we be randomly testing or only testing symptomatic people at this point?
Well, random testing is useful epidemiologically as a surveillance tool to identify clusters, especially clusters of potentially asymptomatic people that can cause greater downstream effects. So I'm in favor of random testing from a public health surveillance perspective. But for managing an institution, symptomatic is probably, if you're symptomatic and you test negative, then there's a high likelihood of a false negative. So you really shouldn't be testing symptomatic people with rapid tests. You should be testing asymptomatic people with rapid tests, right? Because if you're asymptomatic and you test negative, there's a good chance you're negative. If you're asymptomatic and test positive, you're definitely positive. If you're symptomatic and test positive, you're definitely positive. If you're symptomatic and test negative, I'm not so sure. So symptomatic people probably should get a rapid PCR test, not a rapid antigen test.
That's clear. That's good. Should fully vaccinated people be fearful of seeing an increasing number of cases?
Well, yes. Fearful isn't the right word. It's not good. If you're fully vaccinated, it means rising cases means the likelihood of you experiencing a spillover breakthrough infection is higher. It also means your community is in peril, and it means the crisis isn't over. But your level of protection is still good. It's just that it's better if there are no cases around. Again, the analogy I make is wearing rain boots. If you're wearing rain boots in floodwaters, your feet stay dry. But if the floodwaters are higher than the lip of your rain boot, your feet are going to get wet. So watching the cases rise is like watching the floodwaters rise. The second it's over a certain height, then the spillover into your unvaccinated feet is going to happen.
And that makes me, think of the children at the schools. And then the last question here, what are the chances of Delta merging with another non-coronavirus?
Oh, interesting. So, viruses and bacteria can swap genetic material with other viruses, and bacteria viruses with viruses. And so if they both infect the same sick person for a long period of time, it's possible that, hey, I've got this gene, you got that gene, let's see what happens there. So sometimes it happens with the flu. Two kinds of flu infect the same sick animal in like an Asian wet market and lingers for a long time. That's where superbugs kind of arise there. It's possible. Is it likely? I have no idea how to quantify the likelihood of it. It's always possible. That's how these pathogenic creatures evolve sometimes, is they find genes to swap with other people. I have no clear answer, obviously.
Yeah.
Right. No, but I mean, I'm trying to think of, there was a variant a while back that we call the double mutant that may have arisen that same way. It got parts of another virus into itself by infecting one person at the same time. It does happen.
Yeah, I actually remember hearing about that. So moving forward, in summary here, Dr. Deonandan, do you have any words of wisdom for us? How are we going to fare through the next
months
here?
Guess what? This will end, right? This is, I mean, I sound kind of joyful because the worst of it isn't over, but the worst of it is over in the sense that we got a tool, we got vaccines.
Yeah.
We have a way forward. This is not searching through the darkness anymore. We have a flashlight and a knife. We got a way forward. Yeah. So all we got to do is vaccinate everyone, maybe again, you know, use our rapid tests, wear our masks. Nothing's got to close. No one's got to die anymore. No one has to be really sick. So from this point on, every COVID death is a vaccine preventable death. Every bit of suffering is preventable. There's no need for it. And I want everyone, if you care about any of this thing sooner than later, think about pressuring your leaders to make vaccinating the world a priority. Yes. We can make this a Manhattan level project endeavor where we just create enough vaccine and ship it out to the world that we are done with this in months rather than years. What a great way to spend some money. Yeah. So as always, we have it in our power to be out of this soon. This is no longer an existential threat for which we are without tools and a way forward.
Well, I appreciate that. You're always optimistic, but also incredibly informative. And I know that everyone who watches will feel more informed and hopefully also optimistic as we move here into the fall. Thank you so much for your time. Really appreciate it.
My pleasure.